So I invite Dr. N.K. Singh sir from Dhanbad. He is a moderator for our session, that is Dyspnea and the diabetes. Welcome you sir on the stage. Along with this, I also invite all the panelists on the stage, Dr. Parth Sanishwara from Surat, Dr. Udalal from Hyderabad, Dr. Harish Narla from Mysore, Dr. Raka Shivhare from Raipur, Dr. Abhishek Srivastav from Jabalpur, and Dr. S.S. Daria from Lucknow. Yes.
आवाज जा रही है हेलो आवाज जा रही है हेलो हेलो ओके दिस इज ओके I think without wasting time, good evening to you all. I think although this time it is very difficult for an audience to persist for so long, but anyway the show must go on. Although this topic is very important for a diabetic population, for the physicians, every day we are getting such cases. So we are not going to discuss very high sounding things today. I would like to all our panelists, as you see here, I think the Parth is from Surat, he has not come. That Daria is there. So that Udalal from Hyderabad, he is there. That Harish Dala from Mysore. That Raka Shivhare from Raipur. Abhishek, I think, has missed the flight. He will not come. And Dr. Daria, everybody knows he has come. So let us start. I think in the next 1 hour, what is our agenda is that, because I have to cover also this Dr. Parth Sanishwara topic, what are the differentials in your mind when a diabetic patient comes with the shortness of breath. I think this is very important. In my diabetic practice, my workload is something around more than 90% only for diabetic cases. We think that, a patient of diabetes, when he becomes 10 years old, 5 years old, suffering from diabetes, then he can develop the heart failure. This is not the scenario. I will just show you a case just now and then we will proceed. Then we will deal what test we do in diabetic patients who comes with the shortness of breath. Dr. Harish will deal that, Dr. Udalal will deal. A very important test, the NT-proBNP, in evaluation of shortness of breath. And then one of the most important thing to know something about echocardiography to all physicians. It is so important a modality in our clinical practice that for all the new generation doctors, I say you must have some sort of idea about the echocardiography. Dr. Abhishek I told about the management of reduced ejection fraction, we will deal. And then Dr. Daria will again deal a very important topic which we are almost missing in our clinical practice, that is the heart failure or preserved ejection fraction. I think if you know something about all these things, I think our in diabetic cases the quality of treatment will improve. So aim of presentation is the cardiovascular risk that to the patient, despite everything we are currently doing, because of everything we are not doing. And this is very important saying that what we should do for our diabetic patients who comes with the shortness of breath, we are missing something. You know here that such patients which are diabetics are always at higher risk of several CVDs, CAD, CHF, stroke, the peripheral arterial disease and dilated cardiomyopathy, and compared with patients without diabetes, type 2 diabetic patients have a considerably higher risk of severe mortality and mortality. And if you see what is the prevalence of such cases in our country, at least it is 30% to 40%. Because till now there is no clear-cut data in our country. What is the real prevalence of heart failure in diabetic patients? We are just going to start one pan-Indian study for that, and then we will be able to know what will is happening. This patient of hypertension, having history of 6-month hypertension, he was detected. Very young patient, you can see here. And he came to me, for last 15 days, I am getting shortness of breath. And even for the minimal walking, I am getting it now for 10 days or 15 days. Then I did the first random blood sugar. You can see here it was 496. So he was also a diabetic patient now. A hypertensive, complaining of shortness of breath, maybe undetected diabetic or maybe the new onset diabetes. Yes, because the HbA1c shows the 11.5% must be suffering from in the past, but the renal function is quite good. That is the eGFR is 84. If you can see here in the neck, you can see there is some pulsation here going on, and this alerts me. What is happening here? Then I immediately did this X-ray. A bit of cardiomegaly you can notice here, and then just put, because my practice, I see the patients, I prescribe or I advise for the echo, and after 10 to 15 minutes, I go and I do the echo in the same time. I don't send for some other persons because I'm also trained in echocardiography, so I do my go, and the moment I put it, you can see what is happening. I was surprised. A hefty looking healthy man, a new onset of diabetes, history of hypertension maybe 6 months, and when put on the echo, just you can see how the LV is dilated, ejection fraction is how reduced, the functional MR had been developed, and something in the tune of 29 to 34% the ejection fractions. You can see here in this case ejection fraction was 20%, severe TR. Right ventricular pressure was increased. So from here, my first question is here, in such cases with such, suppose before doing the echo, but when this patient came as a shortness of breath, what you are going to think about that? The basic thing when they being doing an X-ray, it will tell you lots of things, whether it is suffering from some cardiac problem or not. Otherwise, you to think about some cardiac problem, pulmonary issues, maybe sometimes psychogenic or airway obstructions, in some endocrine also and central other things are there. And according to the clinical findings, just by doing 2 or 3 important tests which we will discuss with our panelists, you can diagnose. So now here, because this is missing, I think we will just proceed to Dr. Harish Dalla. Suppose in such cases when a patient came to you, how you are going to advise for the investigations for such cases? Dr. Dalla.
Thank you, Dr. Singh. Obviously, yes, we have to investigate the patient, but before investigation, it's very important for us to have the history. History is one which there is no shortcut for it. So you need to know how quickly the shortness of breath has started, whether it's acute, subacute, or chronic, and when does it happen? Does it happen at rest or on exertion? So there is no shortcut of our history, and history will give us almost 50% of the diagnosis. Only based on that you can always do those investigations. So, and then you definitely do a general examination, as Dr. N.K. Singh has already shown. This is not a rocket science. Obviously, from the first year of our medical schooling, we have been taught about history taking, a good history taking, a good complete general examination is very important with systemic examination. So basically, what are you going to look is, you're going to look whether the patient is conscious orientated or not. Like in this patient, the patient was very much conscious and sitting there. So if somebody is tachypneic, drowsy, you think about in your diabetic patient whether the patient is come with diabetic ketoacidosis or not. So you look for pallor. Again, diabetes with kidney failure could have anemia, so you look for pallor. Jugular venous pulse, as has all been shown. Pedal edema again could be because of cardiac issues, renal issues, or liver parameters. Of late, we have seen that NAFLD has been changed to metabolic liver disease now. So you look at the pulse, whether it's tachycardia, bradycardia, do they have brady or tachyarrhythmias, respiratory rate, hydration status, saturation, and a good general examination, systemic examination is very important. So yes, as we all have to base is whether we have a cardiac issue. You look at all those cardiac issues which a diabetic patient can present is congestive cardiac failure, coronary artery disease, brady or tachyarrhythmias, could have pericarditis. Again, that can be elucidated in your history evaluation, acute myocardial infarction or cardiomyopathy, such as this patient who has had a dilated cardiomyopathy, which is very common in a diabetic patient. Then you, not necessarily that all diabetic patients should have a cardiac issue. So always keep your mind open, don't close it, or just have a narrow approach to a patient with diabetes. Look into pulmonary causes, whether this patient has been smoking, known COPD, previously known asthmatic, or with very high sugars, whether the patient has pneumonia. Again, it will be seen on an X-ray. Think about pulmonary embolism if there's a history suggestive of effusion with infection, tuberculosis, pulmonary edema, or even GRD or restrictive lung disease. Obviously, psychogenic will come the last. You think about endocrine causes such as metabolic acidosis, diabetic ketoacidosis, or thyrotoxicosis, where you will not have the other features. The patient will be tachycardic, will be breathless, but again, there could be other features of thyrotoxicosis which you can see. So what are the basic examination or investigation we would order for, and why would we order for? A complete hemogram. Definitely, as I've told you, is anemia, just to make sure that whether this patient has renal, liver parameters and is anemic. You have an elevated WBC count, which could be an acute stress response or could be an infection or underlying diabetic ketoacidosis. Obviously, basic parameters such as fasting, HbA1c postprandial, renal parameters is important, arterial blood gas, to see if the patient has acidosis or metabolic acidosis or could have respiratory alkalosis as well. You would do a basic ECG at the bedside to look at the rhythm. If there's any bundle branch, new bundle branch block, if you have an old ECG, you can always compare it with that. Arrhythmias, brady or tachyarrhythmias, myocardial infarction, acute, and echocardiogram. Obviously, you have both preserved ejection fraction and reduced ejection fraction. They say that less than 40% is reduced ejection fraction and more than 40% preserved. And obviously, the other speakers are going to talk about NT-proBNP, which is a very good bedside marker now to rule out if the patient is in cardiac failure. Now, again, it doesn't, there is no obvious parameters how quickly can it be like a troponin, which has to be done at least if it's done initially and it's negative. You see that the patient has a cardiac event, probably you would repeat it again, but there's no obvious time frame for NT-proBNP. You would do a troponin treadmill test or cardiac catheterization could be done at a later date if you think that this patient has an ischemic event. So arterial Doppler to rule out peripheral vascular disease, or a patient could be an arteriopath. Again, that would be an indication for that. Chest X-ray, as Dr. N.K. Singh has already shown, is whether the patient has cardiomegaly, pulmonary edema, infection, or pleural effusion, etc. Spirometer can be done to look at the lung function. CT scan if it's required, or a high resolution CT scan. And if the patient is obese, you would think about obstructive sleep apnea, where at a later date can do a sleep study. And obviously don't forget a COVID-19, though the incidences come down, but do think about COVID-19 infection. So these are basic investigations we would definitely do in a patient who presents with shortness of breath in a diabetic patient.
I think we are not delivering you a stereotyped lecture. So anytime, any query, you can interrupt us. So I think up to here, I think everything is clear. So the basic test you have to going to do, the RFT, LFT, HbA1c, or other some few things. But for diagnosing a heart failure, suppose basically in our mind, suppose it heart failure, there are 4 steps. Number 1, that Dadra beautifully told about the proper clinical history of symptoms. Then second is most important, the echo Doppler study. The third is BNP or NT-proBNP, and the other test which we are narrating that comes in the step 4. So I think this is up to here quite clear. Yeah.
Up to that point, how we can doubt that patient is in heart failure? Up to the clinical point, let's say, from the chair, from the table.
Yeah, Dr. You respond? Anyone? You.
Okay, again, as I told you, the history is really important for us. So how is that breathlessness is started, whether it's acute, subacute, or chronic. And again, when you go through NYHA grading and see that how bad is the breathlessness, if there is no other fever or cough, phlegm, nothing there, or if a patient is having exertional chest pain, exertional dyspnea, with a good systemic examination such as jugular venous pulse being elevated, patient has pedal edema, patient has crepitations, basal crepitations, and could have an S3 gallop. So there are certain things, and even on a basic ECG, if you see if there are ischemic changes, or you could see tachy or bradyarrhythmias, a new bundle branch block. So obviously these basic history taking, a good systemic examination, and a bedside ECG is more than enough, most often to diagnose a cardiac event or a cardiac failure.
I think Dr. Ghosh wants to know that a patient who is recently diagnosed with the type 2 diabetes with HbA1c of 11.6, coming with the only one complaint, that was the shortness of breath. Why he is not a DK, why he is not having infection? The answer is that when you are seeing the patient and clinically he is having the raised JVP, in that case, already just recently diagnosed with the uncontrolled blood sugar, and X-ray shows you that there is a cardiomegaly. So after seeing the investigation with the clinical finding, then you can go to the directly heart failure. By the history, you are absolutely right. By the history, patient is a type 2 diabetic, presented with shortness of breath, with raised GVP. Yes, it can be a heart failure or something else other. Yeah, family history is always.
Sometimes, yeah. But anyway, okay, so I think to summarize what we discussed till now, that all diagnostic steps are equally important. So you consider Dr. Basab told medical history, signs and symptoms, then confirm with this NT-proBNP, very important test these days. And then confirm by the echo, then assess the clinical phenotype. Once it is in heart failure, you diagnose a heart failure by three things. Number one is clinical history. The second is your this NT-proBNP and echo. And the once it is in your mind, with suppose even the ejection fraction is normal, but suppose the NT-proBNP is high, patient has clinical symptoms, you must also rule out the heart failure preserved ejection fraction. Very important these days. But I think for most of our clinicians, up to this stage, things are okay. And above that, you have to refer. But anyway, you must be quite clear that then for etiological consideration, angio, CMRI, biopsy, or many things are there. So then A, B, C, you are well aware about that. How you do a heart failure is a stage pressure. So basically, detailed workup how needed. I'm not going detail of that. Now I will request Dr. Uday Lal, he is the MD FICP, FICM, Chief Consultant Physician and Diabetologist, Department of Internal Medicine, Esther Prime Hospital, Hyderabad. Because I told you that this is a very important test, the NT-proBNP, and in my clinic there is point of care test instrument. Immediately in 10 minutes you can get NT-proBNP these days. Only 10 minutes is too much. So, sir, you tell me what is the utility of NT-proBNP in evaluation of shortness of breath in diabetic patients?
See how important.
Yeah.
Yeah.
So now you start your slides. So you.
Thank you, Dr. Singh. I think, as you rightly said, echo and NT-proBNP are two tests that are very important in helping in diagnosing heart failure. So I would just briefly talk on the significance of NT-proBNP in diabetic patients. As we know that NT-proBNP is really recommended as a current practice guidelines, not only for positive diagnosis of heart failure, but it also helps in the prognosis and monitoring the treatment subsequently of any heart failure patients. It's a direct predictor of adverse outcomes of cardiovascular mortality. We have seen in some trials like the Steno-2 trial, which showed patients who have microalbuminuria, it was associated with a significant risk only if there was a concomitant risk of NT-proBNP being high. So these patients were at a higher risk for cardiovascular events and disease. while the Pontiac trial also showed that the NT-proBNP can be used very effectively to identify high-risk diabetic patients and take appropriate primary measures. So this would go a long way in helping preventing these set of patients going into heart failure. So we know that cardiovascular is a major cause of comorbidity and death among patients with type 2 diabetes and with coronary artery disease having the highest prevalence. But if you can see here that coronary artery disease, as we know, 68% of deaths are due to cardiovascular disease, but coronary heart disease deaths increase by 2 to 4-fold in this group, and heart failure also increases by 2 to 5-fold. And of course, one needs to also remember that stroke also has a 2 to 4 high risk in these group of patients. So if you just take a stepwise approach, I think Dr. Harish has already mentioned about the importance of history and good physical examination. But if you do tests like the spirometry, pulse oximetry, and electrocardiogram or chest X-ray, you would get about 35 to 40% of cases, you would be able to get a fairly good idea. If you supplement these with some relevant blood tests and an NT-proBNP, as much as 85 to 90% of your diagnosis could be made by basis of these tests. And then you could take a call whether you really need to do a CT chest in one group of patients, or you need to do an echocardiogram to look whether it's a respiratory origin or shortness of breath in a diabetic patient, or we're dealing with a cardiovascular. Or there is a third group which Dr. Harish has also alluded to, the other causes like endocrine, etc., which are not really going to go into details. So now, once we know what is the basic definition of heart failure, we know that symptoms and signs of heart failure are caused by basically a structural or a functional abnormality. And if we can corroborate this with the increased nitropeptide levels, which vary depending on what conditions, I will discuss that a little later. And if we have an objective evidence of cardiogenic or pulmonary or systemic congestion, then we can come to a fairly close diagnosis to say that this patient is suffering from heart failure. So once we know this, so if you have a patient with dyspnea and edema, you assess for, is there a non-cardiac source first? Then you look for the universal definition of heart failure, which we've alluded to already. And then, as Dr. Singh was also mentioning, that you look for any other heart failure mimics, which I'll just briefly talk on. And then you use this H2 FPF score, which basically shows that anybody with a high BMI, you give 1 point. Anybody who is a hypertensive using more than 2 drugs, you give them 2 points. Anybody suffering from atrial fibrillation, you get them 3 points. Anybody who has pulmonary hypertension with a pressure of greater than 35 millimeters of mercury, he's alluded to 1 point. Elderly person above 60, you give 1 point. And anybody with a filling pressure greater than 9 is given 1 point. So if you have a total score of more than 6, then you could be fairly certain that you're dealing with heart failure. So in this stepwise approach, as we have seen here, we need to first rule out some non-cardiac mimics that can, cause shortness of breath and heart failure, like we said liver failure, kidney failure, nephrotic syndrome, anemia. I think all those causes have been already alluded by Dr. Harish. And then there can be some mimics like cardiomyopathy, constrictive pericarditis, etc. And then you look for other causes which could be concomitant problems like diabetes, anemia, etc. This will give you a fairly good idea as to what you're dealing with. So now coming to the levels, as I mentioned earlier, that it varies with age. Now, if you look at the NT-proBNP levels, if the age is less than 50, and if you have a value in an acute setting of less than 300, then heart failure is likely to be unlikely. A gray zone if it's in the range of 300 to 450. And if the values are greater than 450, you could say that it is heart failure likely. This is in the age group of less than 50. And if it's between 50 to 75 age group, if you have a value of 300 to 900, you could say it falls in the gray zone, and if it's above 900, then you could definitely say it's suggestive of heart failure. And in a non-acute setting, patients with mild symptoms, heart failure is unlikely if the values are less than 125, and it would probably fall in the gray zone if it's between 125 to 600. And you could say that the patient is suffering from heart failure if the values are more than 600 if the age is less than 50. And if the age is above 75, in certain areas, 300 to 1800 would again fall under gray zone, and above 1800 would be heart failure. If you're using BNP as a marker, then less than 100 unlikely to be heart failure, 100 to 400 could possibly be dealing with heart failure, and more than 400 would definitely suggest heart failure in an acute setting. And in a non-acute setting, BNP values less than 35, again unlikely. 35 to 150 you would need to consider heart failure, and anybody above 150 is more suggestive. So the key principles in clinical use of this NT-proBNP, you use it in conjunction with all other clinical information. It's a reasonable surrogate for intracardiac volumes and filling pressures. You need to measure in all patients presenting with symptoms suggestive of heart failure, such as dyspnea and fatigue, as their use facilitates the early diagnosis and risk stratification of heart failure. It has a very high diagnostic accuracy in discriminating heart failure from other causes of dyspnea. So higher the value, the higher the chance or likelihood that dyspnea is due to heart failure. So remember that optimal cutoff of NP concentrations for the diagnosis of acute heart failure, patients presenting with acute dyspnea are higher generally compared than those in diagnosis of chronic heart failure in patients with dyspnea on exertion. That's just a mild increase in filling pressures. So obese patients have a tendency, we tend to see lower concentrations. So that's why we mandate to have lower cutoffs for them. So maybe 50% lower is something that you need to take for very obese patients. And in stable heart failure patients with other cardiac disorders like MI, valvular heart disease, or atrial fibrillation, pulmonary embolism, its concentrations have a high prognostic accuracy for death and heart failure hospitalization. You need to screen for NP at the appropriate time. That may help in early detection of cardiac disease, including left ventricular systolic dysfunction in patients with cardiovascular risk factors. And this can also help to identify patients with increased risk, thus allowing targeted measures to be taken earlier to prevent heart failure. So BNP, NT-proBNP, and MR-proNP all are comparable diagnostic and have a pretty good prognostic accuracy. And in patients with shock, you can't really use it to identify the exact cause, but will definitely help you to give you a prognosis on how the patient is moving. And it cannot identify the underlying cause of heart failure, and therefore, if elevated, it needs to always be used in conjunction with cardiac imaging or other tests like echo. Thank you.
I think, Dr. Lal, you have given a very important, last two slides are very, very important about the high accuracy point. And many times this point, last point, whether you missed or not, in obese patients, it could be 50% lower. So this must be remembered. So this is a very, very important test. Next comes the role of the echocardiography. And I thank a very important person from the Chhattisgarh, Raipur, Dr. Raka Sivhare, eminent diabetologist. So he will tell about the utility of echocardiography in the case of shortness of breath in diabetes. Dr. Raka, you take it.
Yes.
Yeah, this one.
Thank you. I can see वास्तव डॉक्टर एन.के. सिंह दिल की बात दिल से करेंगे. संग दिल को संग लेकर संग दिल के घर गए, संग दिल को संग लेकर संग दिल के घर गए, संग मरमर दिल था जिनका उनके संग मरमर गए. तो दोस्तों, we start with diabetes and our patients end in the hand of nephrologist or cardiologist. So being a physician, I am a physician who is doing echoes for last 10 years, 12 years. I have been trained in non-invasive cardiology, and I'll ask everyone sitting here, how many of you are familiar with echo, or how many of you are doing echo? Because my talk will be regarding that nuances of echo, and I'll go in deep dive, take a deep dive only if everybody is liking that subject. How many of you are doing echoes? Yes. If they are doing echoes, then everybody can do. If I am doing echoes, then everybody can do, because echo is the new ECG. And if you are not doing echo also, you need to interpret echo properly, and that's the basic task given by Dr. N.K. Singh to me. And the beauty of this conference is that we are discussing in such a log hours when nobody is interested to reach the hall, we are discussing echo. So going again to the topic, that utility of echocardiography in evaluating shortness of breath in the patients of diabetes. Yes, everybody is saying that shortness of breath has so many causes. You have seen in the physical examination, you have seen with the chemical examination. Now I am going to then lab investigation, which is our heart station. So large number of patients present daily to emergency department with the chief complaint of chest pain, and every time there is a challenge when you have a dilemma, your cardiac enzymes are not properly, you are in a gray zone, chest pain, ECG is not exactly showing ST elevation or ST depression, you are nowhere in the diagnosis, you are in dilemma, then what to do if the patient has same kind of symptoms, where to go. So challenge of physician, being a physician, every time we are in challenge, because nobody takes us so seriously. They take surgeons so seriously, but for we physicians are like GPs. So atypical symptoms, non-diagnostic electrogram, and non-raised cardiac enzyme level, they are the diagnostic dilemma conditions. Mortality and morbidity of ISD improves following early treatment, and we have to judge. मैं अपनी बात बताता हूँ क्योंकि हमारे पास समय है, और मैं अपनी बात बताता हूँ। एक बार एक शाम को मेरे पास एक लेडी आई जिनके बच्चे की शादी थी। वो एक दिन पहले रायपुर आए थे, उन्होंने एक दिन पहले अपनी लड़की की शादी के लिए सारा सामान खरीदा, फिर चाट पकोड़े खाए। दोपहर में 1 बजे मेरे पास आए, मुझे चेस्ट पेन हो रहा है, पर मेरे पंडित जी बोल रहे हैं कि तुम्हें कुछ नहीं है। उन्होंने मेरे चैम्बर में ECG कराए, ECG में मुझे एकदम सटल ST फ्लैटनिंग लगा सर, एकदम ST फ्लैटनिंग लगा, बट क्लिनिकल सिम्टम्स वेर, and she was not at all ready to go for any investigation. She again called to पंडित जी from that place, from my clinic, कि डॉक्टर बोल रहे हैं कि इको करना पड़ेगा, and in echo आई inferior wall में मुझे just hypokinesia, impending hypokinesia, जो पहला होता है स्टंट, वैसा दिखना शुरू हुआ। I said कि इनको लेके जाना पड़ेगा, we have to go for angio or urgent admission. Again Pandit ji, then again other people, nobody takes us seriously, boss. So by that time I have to pick her in my car and rush to Escorts where I was working. And at that time also that relative has not come, and when we get inside that ICU, then the patient was neurologically gone. So such kind, उनकी बेटी की शादी और ऐसा, so everybody should here be committed to know the nuances of echo, and echo is very life-saving. So non-invasive and widely available become the mainstay of evaluation of, here it's right ventricle written, but it's both ventricle in the daily clinical practice. Recent advances in echo has provided so many things which we can even now think of. Tissue Doppler imaging, spectral tracking, they can define whole outline of cardiac chambers, and they can give proper insight. See, these are the different views. आपके पास जो images आते हैं, अल्ट्रासाउंड सोनोग्राफी जैसे images आते हैं, हम सोनोग्राफी के images को नहीं देखते क्योंकि हमें बहुत ज़्यादा समझ में नहीं आता किडनी साइज क्या होगी. But for echo we can have such kind of, we have different views when we put the probe over the chest. These are the different views, and from these views we can get the topographic analysis, where is the problem. If we have that particular topographic area involved, then there would be stunning, This is parasternal long axis view, parasternal RV inflow view, parasternal short axis view, apical 4-chamber view, and subcostal chamber view. Some views are so important to delineate because if you are not going with that chamber view, probably you are going to miss some septal defects or some kind of RV hypokinesia or apical chamber issues. There are so many things which you can take from an echo. And every physician should go for a 7 days or 10 days class to a friends who is doing echo, go and just stand there and get an idea. If you are not doing echo, it hardly matters. But if you are not going to interpret echo, then it also matters. Diabetes, dyspnea, heart failure and echocardiography. Dyspnea is common complaint. Clinical challenge becomes concomitant obesity, sedentary lifestyle, sitting is smoking, diabetes is taken as an angina equivalent, and everybody who is a diabetic is a potential candidate for heart failure. So dyspnea is also a cardinal symptom of heart failure. We have 2 to 4 times increase in risk of developing heart failure in future. This is particularly evident when you have an elderly and especially post-COVID era. After post-COVID era, many patients suffer cytokine storm at home, many have received steroids at home. Nobody knows what happened in future because now there is an entity which ACC and AHA has coined as heart failure with preserved ejection fraction. What does it mean? Initially, we used to call it a diastolic heart failure or diastolic dysfunction. Now they have termed a new term coined for that, heart failure with preserved ejection fraction. What does it mean? Everybody can have that kind of situation if you are have certain symptoms. So echocardiography can distinguish dyspnea between heart failure and dyspnea from other causes. Readily provides information on chamber volumes, structure and systolic and diastolic function. Reduced ejection fraction is heart failure with less than 40% of EF. Everybody reports an ejection fraction in echo report. That ejection fraction we used to see as a simple physician, we used to see only that part, EF kitna hai. But EF is, if it is between 50 to 60, then there comes an area of gray zone. If it is less than 40, then it's a reduced ejection fraction. Diastolic dysfunction, because heart has a pumping function, heart has a relaxing function. Any pumping organ has a relaxing ability. If your heart is not relaxing properly, then it's a diastolic failure, and that has been regarded as heart failure with preserved ejection fraction. So diastolic dysfunction reported, and there are the comparisons of echocardiographic features. ये इतने अच्छे points हैं, अगर कोई echo को seriously करता है, then these points for students and the learners, these are the points. Means a patient who has a right-sided heart failure, who has a left-sided heart failure, who has a valvular problem, who has a pulmonary capillary problem, capillary blood में hypertension है तो कैसे diagnose होगा? These all things can be diagnosed by the echocardiographic values, and these indices can give you different criteria. So persons who are doing echo dedicatedly can differentiate these things. So role of echocardiography, awareness of heart failure. आप ECG करके एक पेशेंट का भेजते हैं, पेशेंट के मन में क्वेरी रहता है, डॉक्टर साहब हमको इको कराना चाहिए क्या? बहुत बारी होता है, अगर ECG में आपने राइट बंडल ब्रांच लिखा, कुछ भी लिखा, IVCD लिखा, तो वो ये चाहते हैं कि there should be an echo. So I request everybody that they should learn the nuances. See, this is a clinical case which I have put specifically for this lecture. Here RV systolic pressure is 60 on echo, and there are the 4 different scenarios who are giving the same things. Means a patient can be diagnosed on echocardiography with same features, and the patient can be different with different diagnoses and can be treated in different way. Here on echo you are getting RV systolic pressure, means you are getting the right chamber pressure, right systolic pressure. RA has to put blood in RV, and RV gets some kind of symptoms if there is rejection of that blood to RA. So you calculate the pressure from TR gradient, means tricuspid regurgitant gradient gives you pressure of pulmonary bed, because it's connected to the pulmonary arteries which are going to pulmonary pulmonary arteries are dipping in the LA. So these are the things. If the patient is having mitral stenosis, then there will be pulmonary hypertension, there will be a tricuspid regurgitation. So these are all the vascular tree. A plumber-like approach should be taken in that evaluating that patient. Here you can see different patients with the same presentation. Here in first case, patient 65-year woman with hypertension, diabetes, obesity, obstructive sleep apnea with classification of 3 dyspnea. Echo has shown left atrial enlargement, normal RV size, function, LVH and diastolic dysfunction grade 3. And here the management is BP control, management is weight loss, and patient is obstructive sleep apnea. That's why dyspnea is there, that we need to go for a pulmonary evaluation, and CPAP and BiPAP will work. In case 2, 42-year-old woman without significant past medical history, 6 months of progressive dyspnea. Sir was talking in history that its presentation is acute, progressive or chronic. Functional class 3, moderate RV enlargement, RV dysfunction, severe TR, normal LV, normal mitral valve function. You need to go for full evaluation of pulmonary bed, that is pulmonary artery hypertension. Patient can learn in core pulmonale or whatever. So 72-year-old man with moderate or severe COPD requiring oxygen, function class 3 dyspnea, echo showing mild RV, normal RV function, mild TR, normal LV function, then you need to simply treatment of COPD and pulmonary rehab. 36-year-old active man, asymptomatic man, echo ordered to screen bicuspid aortic wall because of family history of bicuspid wall in family. That's why the echo was ordered. But when echo was done, there was normal RARV, LALV and walls. Then patient has to go for complete cardiopulmonary evaluation to know out for the cause of dyspnea. And many times you need to have a psychiatric evaluation also. So these are the diagnostic criteria. I will not go this is a detailed criteria of pulmonary arterial hypertension. Those who are doing echoes, they will love, but those who are not doing echo, that will be a complicated topic for them. So I am escaping. And here we have a diagram of dilated cardiomyopathy. Sir has shown in his one patient also. So dilated cardiomyopathy, cardiomyopathies and other ECG correlates can be very well delineated with echo, and echo is must. Thank you.
I think wonderfully presented. So I think till now we talked about the history point. We talked about the NT-proBNP, and we beautifully talked about the echocardiography. So, from this session, if you want to take only one mantra, that is, as Dr. Raka very rightly said, even if you are not planning to buy a echo machine or you don't know how to do it, go and just watch somewhere which is being done every day for 1 week. And you will get the idea of what is happening, and when the reports come, you will have a full picture of how to proceed. So I think this was a very important for you. So till now we will talk about the heart failure preserved ejection fraction by Dr. Daria later on, but some specific echo already I am not going details, but sometimes you can get a valve, no significant LVH, and many times it becomes very difficult. In this case, the EF is 67%, but how it became a preserved ejection fraction, we are not going detail, but these are how this is tissue Doppler is a technique which is very, very important, and that picks up many things about the diastolic dysfunction. So we will discuss later on also. Then we also, suppose you have diagnosed the case as a case of heart failure, then stage B, stage C or stage D, this should be also taken care of. Accordingly, we proceed for other things. Then a very important point Dr. Raka discussed, according to the ejection fraction, these days, if it is less than 40, you say it heart failure, reduced ejection fraction. Quite simple. And if it is less than, then in the heart failure mid-range ejection fraction, that is 41% to 49, and if it is more than 50, I think these three things must be remembered. 41 to 50, 49, more than 40, and more than 50. Then many things in your mind becomes very crystal clear. Now I think the Abhishek Srivastava has not reached so far. Suppose in my case, the ejection fraction was 20%. So in just 2 or 3 minutes before I invite Dr. Daria, I think you can also respond ki what drugs you are going to start in that case, not in an imaginary case, in that case. Which drugs will you start as in the case shown? These days, we have got 4 drugs, very important. Beta blockers, MRH, ARNIs and SGL2 inhibitors. They all see, अगर एक को यूज करें एक बार में कि 2 को यूज करें कि we go through a step wise pattern और चारों को क्या एक ही दिन हम स्टार्ट कर दें? This is a very important question in 2023. And many people don't think, many people just shouted sometimes on me when I told that I will start all 4 drugs from the day 1 itself. And this is the reason. All 4 drugs act across the entire continuum of the spectrum of heart failure, and their therapeutic effects go beyond the conventionally created 3 threshold of LVEF, HREF, heart failure and mid-range EF. So this is very important these days. So I will not go, because this slide is very important. If you ask me why I am telling you कि पहले दिन से ही उसको मैं बीटा ब्लॉकर पे रखूंगा उस केस को, मैं अर्नी स्टार्ट करूंगा लो डोज में, I will start the SGL2 inhibitors, may be diabetic or may not be diabetic, this should be quite clear. अभी फिजिशियंस लोग के दिमाग में इतना ज़्यादा बहम है कि वो सोचते हैं कि SGL2 inhibitors नॉन डायबिटिक में क्यों यूज कर सकते हैं? बिल्कुल यूज करना है फ्रॉम द डे 1, इट इज very important. All drugs, as you see the panoply of pathophysiological mechanisms, it is not just the mechanistic LVEF which contributes to heart failure, but there are also elements of neurohormonal activation, renal function and other non-hormonal factors. ये तभी हो सकता है जबकि आप चारों एक ही बार में स्टार्ट कर देते हो. So that is known as conventional sequencing करेंगे or you are going for the rapid sequencing. So I think you may debate later on, we will discuss, but to be the conventional approach to the implementation is based on a historically driven sequence that is not strongly evidence based today, typically requires more than 6 months because you are only. तो ये कुछ लोग बोलते हैं कि आप फालतू बात बता रहे हैं, कुछ लोग बोलते हैं कि हम एग्री करते हैं. We will discuss if you want how I am saying. Remember, if you start the 4 drugs from the day 1, it will add an average of 6 years of that patient's life. Remember, and I'm not, this is the data from the key trials by this gentleman in the 2023, already appeared in the American Journal of Heart, and this showed how the 3 years average boost in overall survival among heart failure reduced fractions who were 80 years and when using the 4 drugs compared with the conventional medical therapy. So the message is that this new research shows that you should go for the 4 drugs from the very beginning, but definitely you see about the potassium level and other things. So rapid sequencing is very important. If you want to know why I am saying rapidly, it will reduce the morbidity and mortality, efficacy of each therapy. They are the foundational therapy. ये 4 दवा जो है चारों फाउंडेशनल थेरापी है और सबका अलग अलग महत्व है और सब जब चारों को दे देते हैं तो चारों बहुत अच्छा फायदा करके हार्ट को बचाता है. I have seen and we have just started, so you can see here, this is how the American Heart Association says that the low starting dosage of foundational drugs have substantial benefit. You see it. This is a very important message which I want to give you here. Then I will not give, I think we don't have much time now, only 13 minutes. So I think this was the message I wanted to convey. These are the very important slides which is you can download from the site of this American Heart Association or ACC. How to start with the RB or ARNI. I just showing you the beta blockers, how to start which beta blocker. This would be also, and then the sodium glucose SGL2 inhibitors. This is a very, very amrit hai aajkal, many diseases. So with this, I will now request Dr. Daria to tell, we can discuss these things later on. So you come here. I said, so the management of heart failure is this is a very, very difficult situation, I tell you. And I think most of cases you are missing. So you can let's see, Dr. Daria, how can you proceed? If you think about suppose in that case, shortness of breath is there, hypertension is there, and then you think whether you're not getting nothing, then do you think that is a patient of heart failure, preserved ejection fraction or not? So how you proceed for that?
So I'll start where Dr. N.K. Singh left. So anybody have used 4 drugs in your cases till now? Anyone have used? You used 4 on day 1. He said that we should start on day 1. I think, okay, you have started. So can you tell me the history of that patient or the previous medical history of that patient in whom you have started the all 4 drugs? Because in last 15 years, sir, you just showed the slide that there is a rapid sequencing and the non-rapid. In rapid, even he showed that start with the beta blocker and the SGLT2. And then add the MRA and then. So in that slide you showed only 2, start with the beta blocker and the SGLT2. So I'll go further on the preserved ejection heart failure treatment. Preserved is, it means the more than 50. As Dr. Raka said that less than 40 is reduced heart failure ejection fraction. And the mid range is 41 to 49. And more than 50 it is preserved ejection fraction heart failure. So this is the latest guideline by the American Cardiology Society in 2023, and I'll start directly with the treatment. And they said that the guideline mediated medical therapy for the heart failure, they started with the drug class and they use the 4 drugs. The SGLT2 Amrit, start with the SGLT2, and they have seen the DAPA and EMPA. The target dose is 10 mg, and obviously we all started with the 10 mg, and the aldosterone antagonist spironolactone start with the low dose. If you are starting all 4, then you start with the low dose and keep go up to the 50. Then the ARNI, I think I started ARNI in a lot of patient on day 1, if BP allows me. If the blood pressure, that is in reduced, but even I think I have started in the preserved ejection fraction heart failure also, and the results were very good, excellent results. And then the ARBs, the ACC used the only candesartan in that case. Now the drug class in which we should use or contraindication and the your caution. The SGLT2 we know we can't use in type 1 diabetics. Euglycemic decay is there. We can't use in a lactating mother. We can't use on a patient on dialysis. And of course, this is for all drugs, that patient is having the hypersensitivity reaction to that drug. And we should be cautious in a kidney patients where the eGFR, it is, if it is less than 25, on for the DEPA or EMPA, it is less than 25. The pregnancy, Dr. N.K. Singh is doing a real-world study on this, SGLT2 infection, that mycotic genital infections. And soon he will publish that one also. The mRNAs, the potassium is the culprit is there. We have to look for the potassium, and we have to see the potassium for a weekly or 15 days every day, because if it is rising, then we have to stop the mRNA. The Addison's disease, again the pregnancy, we can't use the MRA. ARNI. ARNI should be not used in lactating or pregnant women, and ARNI, the reduced starting dose to the recommended, and what happens, patient is having the reduced or the preserved heart fraction, and he has the other comorbidities also. So if it is hypertension is there, then this is the gold standard drug which can be started on a day 1. So the ARNI, and the last one is the ARBs. Now this is the algorithm which is, I told you, the guideline directed medical therapy. Start with the SGLT2 and then add up the other drugs. So if the patient is having the fluid retention or the NYHA class 2nd to 4th, then give the loop diuretic agent. For a woman who is having the EF less than 55 or the 60%, those with the fluid reduction, then kindly add the MRA. Then you can add the ARNI, and in last you can add the ARBs. So this is a interplay between the other comorbidities. Here the hypertension, the obesity, the diabetes. If obesity is there, then definitely there may be a sleep apnea, the AF, the CKD, the CAD, and finally the patient will end up in the heart failure. The patient is having other comorbidities with the preserved ejection fraction heart failure, then we have to look for the comorbidities also. Like if somebody is having the AF, then we have to see the rate versus rhythm control, and we should not aggressive control the rate, because there may be, because due to the low stroke volume, we can start with the beta blocker or the non-dihydropyridine CCBs, and we should give the anticoagulation if not contraindicated. In hypertension, we can use the ARNI, ARB or MRA. If there is a coronary artery disease, then we should do the intervention guided presentation of the symptoms, then medical managements as a per relevant guidelines. Sleep apnea, of course, if we should go for the polysomnography. If there is a changes in then we can have to refer to the sleep specialist for that OSA, or we should ask patient to reduce the weight loss. And in obesity, again the weight loss, we can use the exercise or the calorie reduction, and nowadays we know the semaglutide or the tirzepatide we can use in that. Diabetic, we all know that we have to control the HbA1c, it should be less than 7 or 7.5, GLP and the other drugs we can use, but the thing is that we should avoid the allogliptin, saxagliptin and thiazolidines, and in CKD, the RAS inhibitors and SGLT2 may slow the progression of your renal disease. This is the selected comorbidities individual where the preserved ejection fraction heart failure, and this is already I told you that association with the heart failure outcome. In hypertension, it is inverse for the mortality. At obesity, it's inverse or the U-shaped. And in DM, it's a very strong that patient may develop with the heart failure, and that can be a reduced or the preserved heart failure. The treatment, already I told you that we should start with the SGLT2 and add with the MRA, ARNI and ARBs. This is a new thing that nowadays the primary care physician, the physician, and then there is a cardiologist. Nowadays in cardiology there is also a heart failure specialist. So according to the American Cardiology Society, that when should a primary care clinician to refer to the cardiovascular patient of a heart failure, and they have given the acronym that check-in. So check-in means there should be a need to specialist to collaborate with them. If there is a high risk features, then hospitalization should be there, pulmonary hypertension or RV dysfunction. If it is an extensive evaluation needed, in that case we have to refer to that.
We have 5 minutes more.
Okay. The cardiorenal syndrome, knowledge for a heart failure, preserved ejection fraction mimics. That is the valvular disease, your cardiomyopathies, the pericardial disease, and if in case need for a diuretic after giving the full dose, then we have to refer to the cardiovascular specialist, or the patient after giving all 4 drugs and still he is in NYHA 3 or 4, then also we have to refer to the cardiovascular specialist. They say that if a cardiovascular specialist is also not able to treat that patient, then they have to refer that patient to the heart failure specialist, and the acronym is for that INHALE. In need of diagnosis, there is a non-responsive to the diuretic or the natriuretic peptide very high, frequent hospitalization for the heart failure, the acute or chronic end organ dysfunction, low blood pressure, and evidence of the preserved ejection fraction mimics. So the treatment of heart failure, it's a skill care team in which you can have the physician, geriatrician, the comorbidity specialist, the palliative care, the heart care specialist, and so on. So this is a checklist for communication to clinician involved in the continuing care, the hospital care, why we have to admit, or the congestion status, unexpected events, plan for the guideline directed medical therapy optimization for a monitor electrolyte and kidney function, and follow-up related comorbidities. Thank you everyone for your patience hearing.
So I think we not only 3 minutes left. Yeah, 3 minutes left. So I think just to summarize, because you But anyway, any question or any discussion in 3 minutes we can do. Otherwise, yeah, sir, come, sir. No, no, no. That yeah. We told about the beta blockers, we told about the SGLT inhibitors, we told about the ARDI and MRH. That is we cannot use the both drugs. That is quite clear these days. You cannot use the same time. You prefer ARNI, but you cannot use both ARNI and this. That is quite clear. I think this is answers your question.
If you are using ARNI, in that case, we cannot use the ARBs.
Yeah. So
Because there is already sartan is there. So sacubitril and valsartan, so we should not use the candesartan.
So I think we will end here with this essential takeaway that we discussed today. We have started with a live case. We showed you the echo of that case and how we diagnose that case as an heart failure or reduced ejection fraction. And we also discussed what other causes could be in such cases. And three things is very important again for the diagnosis or whenever a shortness of breath a diabetic patient comes, you take a proper history, you do a clinical examination, you do immediately an NT-proBNP and you must do an echocardiography. Don't be conservative for doing an echocardiography, very, very important thing. And accordingly, in many patients, it becomes very difficult to diagnose the heart failure pre-heart ejection fraction. We have not time permits now to tell you how to go for that. But I think here we will not add here, but well, don't miss the bus. Again, the message I will give you, the guideline directed medical therapy, that tells you about the 4 medications and you just start the SGLT inhibitors and don't miss the bus. Recommendations already we discussed you about all these things. So take home points. What about the point that you initiated that 4 drugs together? I started 4 drugs together. And patients improved dramatically after 1 week, I tell you. After 1 week, the patient when came, वो बोला कि सर मेरे को तो कुछ हुआ नहीं, आप क्या इलाज कर रहे हो? With low dose, you just have to check on the renal function.
That is only for the reduced ejection fraction, not for the preserved. In preserved, we can't use the all 4 drugs. We should start the only single, then double, then.
Yeah. So I think our time is already over, so we'll end here. So any sir, you want to say something? Yeah.
Normally we send in the lab very concrete test and the report come next day. You said that you are doing in your own clinic. Yeah.
Sir, there are lots of it. Yes, sir, they are point of case. As we are doing the HbA1c in your clinic, in the same way, in the 60,000, there is a very good machine, and it takes only 10 minutes. You can keep it in your clinic, and you can get the reports within the 10 minutes. I every day do it. And the moment I think that सब पेशेंट का ज़्यादा NT-proBNP आएगा, जिसका देखते इको में इस तरह का आता है, they get a huge 4,000, 5,000 NT-proBNP immediately and all symptoms. So this is very, very important. It is not too costly. It is 60 to 70,000.
What is the specificity for this NT-proBNP?
It's quite good, quite good. Apart from other things like in the obese patients, and some many medical conditions are there. We didn't discuss that. Where otherwise NT-proBNP you should correlate. Only thing problem comes when it is acute heart failure or chronic heart failure. But with the history and other things, we also assess that and accordingly we start the treatment.
It is having a diagnostic or the prognostic value. Yeah. In diagnostic, the specificity of these POCs, point of care, around 85 to 86%.
So Dr. Basab, you just tell me whether this symposium which Dr. Akash told me to do, I will not do. I told I will not do in the stereotyped manner. I will tell everyone to present 4 and 5 slides, and we will discuss a live case. So your comment, so and then we will end.
One of the best way of presentation has been so far in so many years. And that should be the approach for a conference.
Exactly.
We all are discussing from the and it's a unique presentation, sir. All you have done.
Thank Thank you so much.
Okay,
Thank
so
you.
with this, I hand over to our chairperson.
Thank you, Dr. Singh, for really nicely moderating the session. And thank you all the panelists for making the subject very clinically interesting. Thank you.
Thank you, sir. Thank you.
Thank you, sir. I request all the speakers, panelists, and the chairperson to collect the memento from the memento on the